Okay, so Professor Wojtowicz will welcome. Go ahead, Andrzej.
Hello, Ron. Thank you very much again for doing this webinar for our implants organization and for all fans all over the world. Thanks to Dental Tribune International, our media partner. We would like to take this opportunity and ask you to give us your overview on the implants, grafting, new developments, research, to give us the guidelines on what kind of research you see now could be most beneficial for implant dentistry. Dear Ron, the cyberspace is yours, please.
Well, good afternoon. It's a pleasure to be in touch with all of you. And I'm going to share the illusion of aesthetics as I see it. I frequently participate in different programs, and it seems like the replacement of a single tooth has become our solution for aesthetics. And I want to point out that there are many problems, and sometimes it isn't, they are not solved by a single implant. It requires the treatment plan of a dentician. And let's take a look at it. Right now, you're looking at the building that is my dental practice. And you see the ocean where the patients sit so that we can keep them calm. It's watching the ocean and the lobster fishermen. We need to define what our success in implant dentistry is. And it is different for a lot of people, for patients. It's different, difficult for dentists to sometimes satisfy patients. And I think that the most important facet of implant dentistry, or any conventional dentistry, is to have a treatment plan that is very clear before we do any treatment. Let's start with something that is very clear. This is a patient that's going to be very difficult to treat. She's in her early 20s, and her central incisor is changing color. And we can see it better here. She has no periodontal disease. So she has demonstrated no susceptibility to inflammation. But now when we examine a radiograph, it's sometime when she was younger, when she was a teenager, she had a bicycle accident. And she had endodontics performed on this tooth. And now we see that we're losing bone and the tooth is resorbing. And if we allow this to continue, it's going to become a significant aesthetic problem. Now, we need to have an approach for this, and we'll see the treatment of this a little bit later. But here is an example of one central incisor, and that's the only problem in this mouth. And this person is not susceptible to inflammation, so we have a very good chance to be successful. How about this patient? It's a relative of a close friend. They were visiting Boston, and the wife of the man was absolutely very unhappy because he had a red tooth. Well, if we only treat that red tooth, he still has a terrible problem that we'll see. We're going to look at the treatment of all these cases. I just want to point out the difference of what we have. Now here, our vertical dimension is significant. It has not been a vertical collapse. There's plenty of pink gingiva where there are teeth, but we'll see there are many, many problems. Now we have a very important lawyer in Boston, and this was quite a while ago. This was in the late 1960s. He had already been a periodontal patient, and I was having a consultation with him. Again, our vertical dimension has been maintained. It's been saved, but we're missing many. He's missing many of teeth, and the teeth that he has are very long. His chief complaint, because I think we have to listen to this. I ask every patient, what is it you would like me to do for you? His problem was that in the court during trials, he began to hold his hand over his face because he thought that people weren't understanding what he was saying. And phonetics, therefore, was his major problem. Of course, if you've read the newspaper every morning, you would find his name on the front page of the newspaper 2 or 3 times a week because he was handling very, very big legal cases. But this is not the type of person that I would like to make a mistake, because then he would be suing me, and I didn't want that to happen. Or we have a captain of industry who, this is a national brand, and we have a lot of people like this in the Boston area, and his wife has been a long-term patient, and he is a pseudo class 3 occlusion where vertical dimension is a major problem. Again, there's plenty of keratinized tissue or gingiva. The soft tissue deficiencies are much easier to work with than the hard tissue or bone. For me, bone is the dictating factor of how we perform dentistry. This is how we make decisions. Good morning. What is it that I could do for you? Well, the response was, can't you see I have no lower teeth? And I thought, oh, that's terrible. And I started talking. While I was talking with him, I realized he did have some mandibular teeth, but he had very poor ceramic crowns that became like a file against the tooth structure until it wore all the tooth structure. So in fact, he had teeth. He just, they had been damaged badly. In this case, vertical dimension is going to become a significant issue. Good morning. What is it you would like me to do for you? And the response was, doctor, are you unable to see? you can't see this? Well, now we have a patient who's obviously going to lose this tooth, but now we have to have a treatment plan of what sequence of therapies to provide and over what time frame that will be stretched. So when we have a treatment strategy, one of the first things we do is employ the biologic width to create tissue expectations. And we'll spend a lot of time with this, but for the moment, we're just going to look at this list, but we'll spend time with each of these. If we're going to extract a tooth, it's very nice. It's very good if we can preserve the buccal plate of the tooth we were talking about. The one we just saw had no buccal plate, but it makes the therapy proceed in a much simpler factor if we can, even if we remove the tooth, if we preserve that. It's realistic to see where the level of bone is. We routinely are able to augment the volume of bone. But on the other hand, if we can treat the patient without doing that, it makes it an easier project for the patient and for the dentist or a surgeon. And we don't, whatever we do, we don't want to lose any more bone. That's very, very important. We also today have to incorporate the lip line in the decision making. So let's see what happens after we extract a tooth. And let's take a look at the two different kinds of patients that exist. We see the design of the bone around the roots, the prominent roots of the anterior teeth, especially the cuspids. In this instance, they're all prominent and there's a little bit of bone loss on each tooth. We're not worried about a tooth like this because if we extract this tooth and if we are able to have some previous experience extracting a tooth, we'll probably be able to preserve all of the bone, and therefore we will not have more decisions to make. A lot of my thinking with dental implants, and I should say I did my first dental implant in 1966, and thank God for Professor Bronnemark. And by 1984, we had more predictability. But now, a patient of a dentist that is nearby me saw the son of one patient. They had a bicycle accident and broke the maxillary anterior incisors. At that point, the dentist decided to do me a favor and extract the roots. But while he was doing that, you can see the red arrows. While he was doing that, he broke the buccal plates in several areas here where you see the red arrows. And in something like this, the buccal plate is here, but it's broken away. And this is something that was only 28 days after the accident. So I asked this dentist to please, in the future, let me remove the teeth. And if there's a fee, I'll give you the money. It'd make it much easier to treat. We don't want to have to think about placing a dental implant after we lose the buccal plate, because now we have to do something about filling this space. There's some very interesting changes in the implant industry in recent time. We can't do the whole story of everything that's happening in dentistry today, where the implant comes in different sizes and different diameters horizontally as it goes into the bone. Let's think about an ideal situation. The patient has lost the lateral incisor. She's in her early 30s. She doesn't even remember much about the fact that it was lost. When we look at the gingiva, we have almost a perfect periodontium here with one tooth missing. Therefore, now we can go from the soft tissue, the gingiva, to the bone. And this case was fantastic. It's a perfect case. The bone is much wider than the implant's going to be. And I could make incisions allowing the interproximal papilla to not be disturbed. So in terms of preserving the interdental gingiva, I have a good chance of this happening. Now we have a decision to make. Do we place the implant at the level of bone? Do we place it occlusal to the level of bone? Or do we bury this for so-called aesthetics? And we will find that question answered over and over as we continue. But I have no thought in burying the implant. There was a study published in 1997 that showed what happens if we place the implant at the level of bone. We may lose a little bit. If we place it a millimeter above the bone stays without losing any. And if we place the surface of the implant at below the level of bone, we're going to lose more bone. This was, I did not do this research. I did not have anything to do with it other than reading. So now we come back to this tooth. You can tell this is old. This happened a long, long time ago because there's an external hex. But there's enough width where I can place the implant in a proper place. We have the two papilla here. The implant was we had a good distance from each tooth to the implant, and this is the result. And we have the papilla without burying the implant. This is a patient with a high lip line again. Her teeth are stained, probably from tracing back to the time she was born. And I think there was tetracycline involved with this. Fortunately, not every human being has a high lip line. Probably 16% or 17% have been thought to have it, and in women, and in men, it's probably somewhere around 11 or 12. And fortunately, also, not everybody with a high lip line has periodontal disease. Look at the radiograph 25 years later. Now, I know this is a very long dental implant, but 25 years ago, our thinking was to engage the bicortical bone. That means both at the occlusal and at the apical level. So we've managed to grow this whole area, and we have lost maybe a half to a millimeter of bone, and that is probably relative to the implant abutment connection. Let's think about what our possibilities are. We have a very nice looking dentition. Again, a young person. And there's a major problem around this lateral incisor. So we have to consider what are our choices here. One, we can just extract it and do nothing and put the soft tissue back, and probably it will collapse. Or we can do bone grafting here, with or without a membrane. and put the flap back and wait for, really, if you really want to have the best bone, you've got to wait 4 or 5 months. And then come back and place an implant. Or we can do bone grafting and soft tissue grafting. It's a combination therapy. But when we see this defect, we have to come to grips with, what are we going to do? This is not a vertical dimension problem. It's not an occlusal problem. It's one area in the mouth. So this was treated with a bone graft and then a resorbable membrane and then a connective tissue graft, and then everything was sutured together. This is the type of surgery that a patient can get along with very well, because it's a limited area. If this is a entertainment or a television person, I don't consider television to be entertaining, then we prepare a massive edge prosthesis that we can connect to the adjacent teeth without damaging them, and just leave it alone until we're ready to put the implant in. It's obvious, the grafting is obvious. There's a lot of bone missing, and now we have a lot of bone. And we can see where we had the extraction missing. Notice these are very small surgeries. But a lot of the time, or most of the time, we use a navigation system to be sure we have the implant in the best possible position, so that we can get an optimal result for the patient. And this is a happy patient. And it's somebody who, from a business point of view, will refer friends because she can't believe how well it turned out. I can take no credit for the crowns because our practice was limited to periodontics and adult orthodontics. Now, one of the things that we've used in some of these projects is platelet-derived growth factor. I know this is not universally available, but this gives us an opportunity to have an intelligent conversation. The first bicuspid, maxillary first bicuspid, has a buccal root where the periodontal probe is, and it has a palatal root where we can see the hole of that right here. The question here is, should I put an immediate implant here and graft it, or should I, and wait, because that's going to, again, be 4 or 5 months till we're ready to do something. And the alternative is to put it, just to do a bone graft and then put the implant in. Until 2019, there was no human evidence of the bone to implant contact in a extraction wound. You cannot predict or accept that just because a radiograph looks like bone, that there's bone to implant contact. But we published a study last year and found that we could get about 65% bone to implant contact in the human when we biopsied it. That would be plenty, that's significant to support an implant. The same implant in areas with healed bone were 74. So 65 is really roughly a good area. Now, once again, this area was grafted. This is with PDGF together with a xenograft. And the wound is closed. This is easier for the patient because it's a first bicuspid compared to a central incisor. And we're going to wait 4 months. Look when we make the space for the implant, when we drill for the implant, look how much control we have, both mesiodistal and buccolingually. We have an optimal position to put an implant. And for many, and especially almost all posterior implants, this is a conversation that we should have with ourselves. Okay, we've extracted the tooth, but what is going to ultimately be the best result we can do for the patient? And I'm sure that in every one of you that is paying attention, that's an ideal thought. This was only 4 months, but it worked out fine. Now, we have a preserved C, the first dentition, or some people think of it as baby teeth. This is a cuspid, maxillary cuspid. We can see the space where there's granulation tissue here. And now we're back to the bone being the prime dictate factor. So we're going to have different levels of bone. We have the interproximal level of bone, and we have the buccal is different, and the palatal is about the same as the interproximal. I make my decision based on where the interproximal bone is, because that's going to control the papilla, which is an issue. Here you see the implant in place. Now, if you look at this person's dentition, her cuspid, her permanent cuspid with the dental implant fits right in with her dentition. And we have no problem with black triangles interproximally. This really is dealing with the prime dictate factor being the bone and how they place the implant. As we look at 1998, when this patient was treated, and we look at the bone in 2007, and we look at the bone in 2013, she moved to the West Coast of the United States and is a fashion model, but I can't get any cooperation from her in terms of a longer-term radiograph. But for the first 15 years, we're right about where we left off. So now comes the decision tree at the time of extraction. Should we do regeneration and come back later and do an implant? Should we put an immediate implant in place? Or should we just extract the tooth and let it heal, and then however position it is, then we'll start grafting at that time? My direction of answering the question is, what would I do if it was my tooth? or my wife's tooth, or one of my children's. Sometimes you have to make these decisions. Let's take a look at a study that we did. Back in the 1995 or so, I was the principal investigator for the research on bone morphogenic protein 2. This BMP was recognized as a factor in bone healing in the 1960s. And they just, until we had the studies in the 1980s, nobody knew what proteins' behavior were going to be. It was always a conversation. So if we did a control, and there's a very little line here of bone, if this was just open and clean out the tissue and hope for the best, then we lost everything. Let's look at some where we used the BMP. The BMP is a liquid, and it's placed on a collagen material that will absorb it and release it properly. So here, now we've extracted the tooth, and it's not as long or occlusal as the palatal tissue. Look how much stronger the palatal bone is than the buccal. And in using this for 4 weeks, look at the result. No bone material at all, just a liquid and a connective tissue. You see the red arrow, and this is a cuspid, and that very thin buccal plate. Again, we're just going to put the liquid, it's put together with a collagen carrier. And look at what happens. So, some of this, if you're practicing and you're doing a lot of implants, as these things happen, it's almost like a miracle. Where suddenly we have tools that we can do things that we weren't able to do before. And if you say, is it really bone? Yes, it's really bone. When we would go in and take a biopsy and have histology done, this is absolutely real bone. So, we have a professional hockey player, and he had a terrible accident during a game. The 2 teeth had to be removed, and we have no buccal plate at all where it says concavity or with the yellow. This is not a day with the bone lost up here completely and no buccal plate here. This is not where we should be even thinking about a immediate implant. We first have to rebuild the area and see what we're going to have. So now you can see the same area after the bone graft, and now there's 2 implants in place. It's the success of many of these decisions is in the treatment plan. When are you going to do it, and what are you waiting to do? In another study, we extracted teeth and did nothing, or we put a xenograft into this space. And this looks like a very good buccal plate. It's the proper height. It's wider than the earlier, although it is pretty thin at that area. But what's going to happen in a short period of time? This was 28 days. We lost the entire buccal plate. Whereas when we put in the grafting, when we came back to it, we had no problem placing an implant. So the decision of when to take the tooth out and when to place the implant from a time point of view becomes very important. If we tried to place an implant here, it's going to be too far to the lingual, or it's going to be at a strange angle. But to do this perfectly, we're better off if we do that. Then these are a couple of other opportunities from the same study. Here's a buccal plate. In 30 days, it's almost nothing. Here's another one when we put nothing in here. And if I don't remember how many we did, 50 or 60 teeth. This was published a long, long time ago. But even if we look at something like this that we expect to be good, if we treat it with the graft, we're a lot better off. So we make our first visit to the group that we were looking at. In this instance, obviously, we have to eliminate all of the debris, calculus, off the surface of the root. And now, in cleaning this up, we're going to have to do some grafting for soft tissue and then come back after that. And we went to the chin and we took a block. You see that together. And now we have made the transition from here to here. But this first required a procedure just to get control and let the soft tissue heal. And then when we had soft tissue, then we could come back and do a block graft because you want to be sure you can cover the graft. This is the way the bone was, very thin. And here it is after the grafting. It's wide. This is the stent. And we can see if we come in here, we'll be right in the right place for an implant. Frequently, we don't see the patient until many years after their accident. And in this instance, it was a bicycle accident, and both these teeth were lost, and the patient was a young man with a partial denture that he wanted to eliminate. A stent was made, and because the buccal plate was destroyed, we put it, this was back quite a few years. We published this in 1996, but I think that the procedure was done in the 1980s. And here we're going to place the two implants on the lingual portion of the tooth rather than through the occlusal. Here we are. At this time, we were still doing every case in the hospital, and it was, we had to go with all the rules of the hospital with anesthesia and et cetera. this was a lesson. We finally, I got the implants in, they're in a good place. And now the question is, what's going to happen to the papilla between these two implants? The patient the prosthetist made 2 provisional crowns. And we left it that way for some period of time because he was living somewhere else, and then he came back. And when he came for his visit, and I unscrewed the 2 temporary crowns, the papilla developed by itself. It followed, the tissue followed the bone and also into the interproximal place. As we continue with this thought process, and I'm going to get the single implant done first before going into the bigger cases, because we have to take what we learn in small areas and put them into big areas. Here, there's plenty of soft tissue, plenty of gingiva, but the patient has a crown on this tooth. It's had 2 apicoectomies so far, and they're unable to solve the problem. The radiograph looked quite calm, not a problem, but nevertheless, the fistulas continued to appear. So, in extracting the tooth, we've lost a lot of bone. And again, if we try to get the bone to implant contact when we have so little bone left, it's a gamble. Can it work? Is it possible? Sure. But if you have a patient whose chief complaint isn't going to be solved, then we have it's too much of a risk. So this area was grafted, and we waited 6 months, and we could see radiographically and with probing that we had bone. So this gave me the advantage of keeping the interdental papillae. No matter how you try to build them, it's better to preserve them. And here we have plenty of room to place the implant. And our gold standard is to be inconspicuous, that you can't tell the tooth that is supplied with the dental implant from the adjacent natural rooted tooth. First, we look with the patient has a high lip line or that direction. We can see where the apicoectomies were done over this tooth. But look how orderly the result is. As we move on, we're going to be talking about the importance of the patient being able to maintain the cleanliness of the area. Now, with people with just one single tooth, and they're in their 3rd or 4th decade of life, and they show no susceptibility to inflammation, we can work through cases like this with a very well orderly situation. The patient was referred by a prosthetist. She was I want to say famous, but a very important psychologist in the Boston area. And this is her home care, where we have plaque here and here and calculus. And the dentist that referred her told her that if she came to see me, she'd have all separate teeth, and it would be very easy to keep clean. For somebody who doesn't have any idea, she's almost 50 years old. Our first goal was to see if we could make her mouth clean and she could preserve the cleanliness before we go any further. And actually, her appearance was better with the plaque than it is without it. But the dentist then made a provisional bridge. And when I opened this up, I said, we're going to make a very bad mistake here, because the buccal bone on the lateral incisor was missing. Just having a thin layer of bone is not quite as predictable as rebuilding bone. There's just an awful lot of damage here. I attempted to convince her to let them make the bridge from, let me go back one. Make the bridge from the central incisors to the cuspid and extract this tooth. And I'll graft this and fill it in. But I could not convince her to not have the implants. First, I grafted this area, and then I was shocked at how much bone I was able to develop. Again, you can tell how old this was because it's the external hex is here. When we talk about biologic width and crown, providing a crown for a margin to be placed, this is a very good area to look. Here you have maybe 2 millimeters or so, and the first millimeter of healing will be connective tissue fibers, and then you have a millimeter of epithelium, and then you have the area where the margin is going to be of the new crown. Our way of practicing is that every new crown should have a margin on sound tooth structure like this, not on this type of surface. So it's a matter of providing some tooth structure. But this worked out very well. In doing this, I decided, I don't know why my computer is doing that. The idea was to provide her something that she could keep clean and something that would be aesthetically pleasant. I don't know of any research that has shown that the titanium, a polished titanium ridge can be put together, will heal attached to bone. So we may as well just put it above the bone rather than put it into the bone and then lose the millimeter. This person has a more normal smile. And well, this was finished in 1994. Everything was in order. For maybe 5 or 6 years, she came to my office for her maintenance. My office is about 14 miles north of Boston, right across from the ocean, as you saw. But she lived in Boston, and it was a nuisance for her to come. So I lost touch with her. And then my son is a periodontist in Boston. And he said, I met a patient of yours I said, really? He said, yeah, she came and she's going to come to see me for maintenance. And I said, great. Here she was 12 years later. We had some recession around the natural tooth cuspid, but the implant and the interproximal soft tissues were a fantastic finish for her, considering how she presented. We have, this is a dentist who teaches at one of the universities. And she had seen me lecture and she came out to the office and I wanted to know what should be done. She had the same type of post and core in both central incisors, but it doesn't show in this radiograph. But there were two of these and this. And I suggested, why don't we remove this tooth? We'll rebuild the bone. We'll have a cantilever from the two central incisors. Well, these will be implants. She absolutely did not want me to do anything with the central incisors. So now this left me working with this tooth. And I grafted the area and I had a lot of room here, so I put a big implant in here and to see what would happen. Here it is 15 years later. You got bone to here and bone to here. And here you can see the two central incisors are still there. The problem I had was with the soft tissue. I charged the patient nothing because she's on one of the faculties. At rest, it's easy for her to look good. This was after 3 soft tissue surgeries. She didn't mind because I wasn't charging her. And this is the resolution for her situation. But this took 3 more soft tissue procedures to get to this point that I would be satisfied in my mouth. And finally with this, we have a patient who's referred for an implant. The patient tells me immediately, I never want to have an implant. My mother had implants and they all failed. Of course, I never met her or her mother before. And I said, well, what shall we do? And she said, well, what are my choices? And I said, well, I've practiced for a long time and there are a lot of 3-unit bridges that work very well. And if we can build this area up where there's no bone, then you'll be able to keep it clean and the tissue will be at a reasonable level. So believe it or not, in the age of implants, this patient selected a 3-unit bridge. So the whole story of surgery in the mouth is preserving the bone and preserving the soft tissue. And you have to take this into mind that you have the commitment. Once you get in there surgically, you have the commitment not only with the gingiva, but also with the bone and finding the way to get the best answer to the bone. How would you feel when a patient travels a long distance? Her dentist in the islands off of Florida insisted that she come to see me, and you can't really put an implant into here. You might say, well, I can put a chisel and I will chisel right here, and the chances are good you'll break off a piece of this and it'll be worse. Also, the soft tissue is terrible. So now the question is, what should I do first? Should I build the bone first or should I build the soft tissue first? And I've told you that bone is my prime dictating factor. So here you see the bone. I'm going to go to her chin and take a block of bone. And now that green arrow is the way it began. And now we have plenty of bone to put a nice implant. So that was the way the soft tissue was. That was the bone graft. But because we used I disconnected a lot of the buccal tissue so I could bring that towards the lingual. And suddenly we don't really have a soft tissue problem any longer. Now she went back to her dentist on the island. You can see there. Here's what we had to work with for an implant. Here's the implant. And I've seen better prosthetics in terms of, as you have seen so far. But as I told you, we don't do any ceramics in our office. We don't do any crown and bridge in our office. And this is what she had done. But considering where we began, this is a very nice answer for her. Now, suppose you have this big loss of bone on a lateral incisor. And to patients, the mandibular teeth are important too, not just the maxillary incisors. And this person had this whole nice block of bone right here. So I'm sure what you can guess is I convinced her that it would be very good for her diet if she let me take this piece of bone and place it here. And I used some graft material, allograft, around the block of bone, and makes everything come out nice and clean. So we have native bone, just the graft block. We have the allograft. Is this? This is one. This is two. Is the native bone, and three is an allograft. So, excuse me. We had the torus, the native bone, and the allograft. And taking all three of these and putting them together, putting a membrane, and here it is healed. Now we have a stent to put the implant in. The mandibular lip, you really can get along with some recession because the patient doesn't see it. But you can see the implant is in a very good place, mesiodistally. And if you look at the bone is, all the threads are covered. So now we come back to the case that we started with today. where we're having loss of bone and loss of tooth structure in a patient who, I don't know, is 23, 24 years old. As we look at this in the three-dimensional radiograph, we have a very thin bone, buccolingually. So if we are going to do this without surgery, we're going to remove the tooth. We have removed the tooth, but we're going to go into here without surgery, without flaps. We're only going to have one chance of going in and placing it without the implant coming out of the bone. So we need to prepare something that will help us guide the implant and be in bone. We can see what we're trying to do here. We want to preserve the bone on the palatal and on the buccal. Very simple. We have the laboratory make this little stent for us. And we don't want to do surgery here. We don't want black triangles in proximally. And our result is close enough that she's ecstatic. Coloring is pretty good. And if you notice, without anything else we did, the bone filled in here. And we're up to the top thread here. But again, we have our two categories of patients. One we have with tremendous susceptibility to inflammation, and one we have where they're young people, and we've got young tissues to work with, and we have no inflammatory disease. Sometimes we can look like a magician. But we immediately turn to a high lip line in a dissatisfied patient. He has ugly restorations, both lateral incisors are held in place with acid etch prosthetics. She's another young person, and we're going to find an answer for her. As we look at this with a two-dimensional radiograph, you can say, oh, there's plenty of bone. But when you look at the bone in the CBCT, we don't have implants narrow enough to fit in, so we have to do something to build bone. And here you see the bone has been built here. You can see the membrane is reinforced. And we were able to get enough expanse to have two lateral incisors. And the then she also had two new crowns on the central incisors, so she had 4 new restorations. You can see, or 6. You can see the restoration here, 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 and here. So she has a fantastic appearance, and very happy with where we are. If we had black triangles in these teeth, especially between the central incisors, the patient probably would not be that appreciative. So it's this constant message of we have to think through what we're going to do before we do it. This is 2 years later, and this is 6 years later. So that more or less finishes what our possibilities are with a single tooth incisor. There is no program that I have been on in the last maybe 5 or 10 years where there isn't a lot of attention paid to the single tooth, and that's called aesthetics. And now we're going to see some real aesthetics. How would you treat this patient if it was your patient? We're going to have a lot of bone, but you can't put the implant here. You have to build this out. So we have to get to this point so that we can get implants in and look realistic. It's not going to help to have them if they're too far lingual. So here's the patient. She has this large partial denture. This is a psychologic problem with her. And she'll do this. She told me plain out, I'll do whatever you want me to do if you can help me. So it was obvious that we had to build bone. And it was obvious that we couldn't get a piece of bone big enough from intraoral. So we had her in the hospital and under general, and we opened up her posterior iliac, and we harvested cortical bone. But that was a big feat to come up with anything that would help us. You can see here how far back the bone is. So we had 2 thick bone grafts, and then we scraped up some other bone from around the area to fill in different areas. And suddenly we had something out here. And then on the next step, we had no soft tissue here. So we did 2 big grafts. After we had them, I was able to get 5 implants here. There was in 1998. I can't speak for every dentist, but dentists have different capabilities between the dentist and laboratory for aesthetics. Now you've seen some excellent. This is great for the patient. This is 22 years later, and she's doing wonderfully. But if you said to me, "You're so fussy, how do you let this happen?" Well, that's her dentist. But here's her radiographs in 2019. What I'm driving at now is these are really the aesthetic cases. The single tooth is great for your practice. It's something that you cannot afford to make mistakes with. But on the other hand, if you have the capacity to work with treatment planning, you'll be okay. Let's look at what kind of problems we can have. We saw this patient for the first time, and I said, "Do you have any older pictures?" And she was in her 40s, and she said, "Actually, I do. I did a lot of modeling when I was in my late teens and early 20s. It was before my first marriage. And, I said, well, when you come next time, would you bring some pictures from that? And these are a couple of her pictures from when she was a model. Unfortunately, and this is the appearance of her teeth on the first picture. We had one of our photographers took one of these pictures and put it, and just cut out the mouth for us. But here's how she looks now. She has had a very difficult life. She's had trouble with alcohol. She's had a little trouble with drugs. Her children are very difficult for her. And in thinking about what to do, as we spent a lot of time with it, the first thing I did was arrange for her to go to a new hairdresser so her hair would look better. But she's lost bone. Now we're into susceptibility of inflammation. And she does not have the money to do distraction osteogenesis, nor does she have the intellect to try something like that. I finally said, I think what we could do is if we just extracted the 4 lateral incisors and built a fixed bridge from cuspid to cuspid, this would be fine. And you would look great. She didn't like the melanin in her tissues. I said, I know we can remove that. And predict that it won't come back. And we talked and we talked and we talked, and then she decided she could not afford to do anything. But you don't win every case, even if you learn a little bit. So now let's start with somebody with some advanced periodontal disease. These 2 teeth have to be removed. I don't have it here, but there were infrabony defects that needed to be treated to save teeth all over. And finally, we got it from 94 to 2000. And at this point, we had a discussion about replacing the 2 maxillary anterior teeth. I told him that I thought he should have a fixed bridge because the teeth with the implants were going to be longer than his natural teeth. And over these 6 years, he became an expert on cleanliness. He was a physician himself. He argued back to me that it doesn't make any difference because nobody can see my teeth. So I'd rather you don't let my dentist make any crowns. Just do the 2 implants for me. And I had promised him that someday I would do 2 sinus lifts and yeah. So the bone is considerably apical compared to where the bone is for the teeth that are still there. And you can see that I'm putting the bone in. I'm not burying the bones, the implants. And these 2 teeth, these 2 implants are going to be longer than the other teeth. But you know what? Oh, and I did do the sinus elevation and 2 implants that I promised. And you can't see the infrabony defects any longer that were treated. There's still having a problem in this one area. But this is his smile. He's totally satisfied because he has a low lip line. His hobby is climbing up into trees and sitting there for the day, hunting black bears. This is, in his life, this is where he gets his satisfaction. But there is a time when you have to think differently to work with what the patient's anticipation is of a result. On the other hand, good morning, welcome to our office. What can I do for you? And for the second time in my life, I had somebody say, well, can't you see what my problem is? And I said, well, I see what your problem is, but I wanted to hear what you think. And I wrote down everything that she thought. When we put cheek retractors, if we can see this much of the root, you know you've lost a lot of bone. Because the bone will not be right here and here. The bone will be up here and here somewhere. So I arranged with a dentist that she saw to make a provisional bridge and to come to my office for the surgery. And I had the opportunity, after I extracted the 4 incisors, I had him make a provisional bridge to bring with him. And you can see how far away the implant is going to be from the plastic. Now you might say, well, you've shown grafting, you graft and have had some success with grafting. The problem is that there's no bone from the buccal to the lingual. And sometimes it's beyond, the damage is beyond where you're going to be able to manage it. And these pontics already are long. And if we look at the radiographs, you can see where the bone is. As I keep saying, you have to sit in a different position for people who have demonstrated they're champions of being subjected to inflammation, where they just they're susceptible to this. We don't know why, we don't know how to fix it, but in a lot of adult patients throughout the world, this is what you've got. And this is a gamble. If you're going to try to stay with some of the natural dentition, I know you're going to say, well, we can do this with all-on-4. But what do you do with all-on-4 when one of the implants fails? Or worse yet, if 2 of them fail. So we get into a conversation of how far can you put these underneath? Now, I was in a lecture, I was on a panel, I'll just say in another country, and the person after me before lunch had magnificent clinical pictures. And at lunch, I congratulated him, and I said, you know, your photography is fantastic. And he was feeling very good about things. And I said, there's one picture in your lecture that I would like to borrow or to have. And he said, you can have my whole lecture if you like. I said, no, I just want one lecture, one photograph. What he had done was he extracted 2 maxillary anterior teeth because of bone loss. Now he's placing the implants. This black is 5, so it's 6, 7, 8 millimeters subgingival. No patient or hygienist in the world can keep that area clean. And there's a lot of times there's a little micro gap. With a micro gap, you're losing a millimeter or 2 of bone, and it can get worse. It can get worse. Peri-Implantitis can almost be eliminated if we really carefully follow the rules that we're talking about today. The end point, you have to say, what do I want to have when I'm finished with the treatment? What I want to have is an area where both the patient and the hygienist can keep the area clean. If your patients are susceptible to inflammation, like this, you're going to have problems. A dentist called and said, I don't know you, but I know you've been doing implants for a long time, and I've got a patient that I am treating, and whenever I stop the antibiotics, we have an infection. And he said, can I bring her over and let you take a look and see what's wrong? So I figured, well, I'll be a nice guy and do that. And he came with the patient. You can see the 2 fistulae. And now we look at the implant, and this one is doing okay, but look what's happening here. And I said, well, when did you do these? How old are they? And he said, oh, I don't know, maybe 5, 6. I said, oh, it's 5 years old. He said, no, 5 months old. I said, did you do anything with the lateral incisor before you put this implant in? No, and I could get the implant in. Why should I do anything here? No. This is what you run into. I can't picture the same thing here, but not good. Or a new patient came and was referred to me, and I'm looking at it. I said, let me make new radiographs, and just so that if in the future, because she was going to live in Boston, I can compare it to something. These 2 implants, again, were 5 or 6 months old. They were done on the West Coast of America. And how can you leave this tooth? I mean, what patient or hygienist can clean this? Wouldn't it be more reasonable to extract it and build the 3-unit bridge to the 2 implants? But this is an amateurish mistake by a dentist. It's absurd that somebody that has this little knowledge is allowed to be putting implants in. You really have to know what damage you're going to do. So we come back to our famous lawyer, and the first thing I told him, this is from the beginning, is if you think that extracting all these teeth and putting a denture in your mouth is going to improve your phonetics, I'm sure that you're going to be disappointed. So I think that what we should do is remove some teeth, and we're going to make a provisional bridge and see how you do. And he did well, and eventually we got the case finished. I was very fortunate. I had the opportunity to work with some wonderful prosthodontists. So there was no need for me to deal with that. But look at the difference of these two denticians. One, he's embarrassed, he's phonetics. As we get here, these are 4 pontics, so if he puts the dental floss here, he can maneuver it to here, to here, to here. And the same with the mandibular incisors. But you don't have to do an implant every time. So back in 1968, this woman presented as a patient. Her husband, at that time I'm at Harvard University for the past 25 years, but I was at Boston University then. And her husband was a tenured professor at the university, and she was in charge of all entertainment for the president of the university. If you taught this woman how to use dental floss, she would extract her own teeth. But this is not the day to talk about a consultation. We cut off the 2 roots here, and this is the way we splinted in 1968, we did this type of thing. Don't ever splint like this. And after 6 different visits of cleaning her teeth, the first day we cleaned her teeth, we cut off the roots, did the stabilization. You can see. Then the next week we brought her back, and after there was some shrinkage, we did another prophylaxis. And then for the next 4 weeks, we did quadrant root planing with anesthesia for 1/4 of the mouth each week. So by the time I saw her for a consultation, she had been in the office for 2 months, 8 weeks. And this is now, I have some important information. I have a patient who wants to be helped. She keeps her appointment. She pays her bills. More important to either, she cleans her mouth every day the way she's being taught. Now we have an issue. The tissues are pink and they're not bleeding with probing, but that's not the same thing as periodontal health. Let's go to a different case. This was for a project we were doing for the FDA for a new product, recombinant platelet-derived growth factor. So make-believe the patient wanted to have implants distal to the molar. And what I would say to the patient is, you can't have implants in your mouth until all the periodontal disease is gone. But now this is probing almost 9 millimeters in depth, and she is doing a fabulous job cleaning her mouth. She's been through the same kind of program. And the question I would have to ask you if I was in person would be, how many of you would now say that the periodontal disease is under control and it's okay to place implants in this mouth? However, if we look at the problem, we really have an important situation. We have a defect. It has a lingual wall, but it's missing the buccal wall, and it's missing the distal wall from the tooth. I don't know why this keeps changing, but excuse me. And here you can see the radiograph, and you can see there's a space between the 2 teeth. The tooth was stable. It's a big root and it was stable. Even though it had very little tooth, the clinical root. There's an awful lot of bone missing, but the tooth is stable. You see, this is not periodontal health. Not if you have this type of damage. When we talk about infrabony defects, we talk about contained or no contained, because that's how you control the grafting. And here you only have maybe 1 millimeter. We could say maybe 1.5 millimeters of containment, and the rest of this is uncontained. The odds of getting regeneration are not great here, except for the fact that this tooth is stable. This was treated with the GEM21, the platelet-derived growth factor, and this is sutured. Here's the picture 3 days later, because the protein, the PDGF, tends to be used for years and years for diabetic wounds on the legs to cure the soft tissue. So it's working here too, but what we're interested now is with bone. So there's the defect. Reopened in 1 year, it's changed to this. It's got 1 or 2 millimeters of probing. We could take a little chisel and chisel off a little bit of bone right here. And we don't want to leave any depth here, because this person has proven that she's a champion of susceptibility. So we're not going to let anything stay behind. Here's the original, and here it is 1 year later. And if you say, well, 1 year, what happened after 1 year? Well, here's 3 years. Notice there's no diastema between the teeth anymore. And we did nothing about that. They just drifted back together. Here's 6 years. Here's 10 years later. And think about it, if that tooth was in your mouth, wouldn't you, and you know this could happen, wouldn't you try to save your tooth? At this point, she ran out of money, didn't have any. Now, with the woman who is that works for the president of Boston University, her chief complaint was aesthetics. And you could think, should we put an implant or should we not put it? But if we put an implant here, she wants aesthetics, I'm going to have to bring the soft tissue to here. I can do that, but that's now going to leave here with a probing depth of this far. And she is so sensitive to inflammation that this is the wrong person to do that, because there's no way to keep this clean. And if we want to talk about peri-implantitis, this is a great possibility of how to create peri-implantitis. So even though there's enough bone for a very long implant, this is the wrong place to do an implant. We looked at the picture. But again, we have the endpoint goal of being able to take care of it. So here are her original radiographs. She's 38 years old. And you almost can say, which teeth can you save, not which teeth are you going to keep. All 4 maxillary molars have a 3+ mobility and are trifurcated. And this first bicuspid has a furcation involvement through and through from mesial to distal. These teeth can't be saved. we don't have the time to go through a treatment planning of tooth by tooth. But look, all the bone is missing here, and here the bone is all okay. The only thing we've got to do is take out these two teeth. If we remove these two teeth, then this tooth is worthless. And this is a through and through furcation, which nobody has ever been able to demonstrate in a human that you could have regeneration of that. There's no such thing as the histology. We published the human histology of a class 2 furcation in the year 2003 with the platelet-derived growth factor, and to the best of my knowledge, that's the first human histology of that, to show that it is possible to do. But that's not for today. By 2 years, we had the prosthetics finished. That was the provisional bridge, and that was the permanent bridge. This was 20 years later. We did her in 1968, here's 1988, and here's 40 years later. She's never had caries. She's never missed a visit for her cleaning. She's never had surgery again, and she's never had endodontics. But we were accustomed to working with these type of patients and problems. So we talked about the pink ceramic solution, and we began using pink ceramics in the early 90s to try to help us get through some problems, because people want to look good. So here we have somebody in provisionals, and she didn't want anybody to know that she was having all this dental work. So she insisted that her new work would have the same spaces that her original teeth had. So this was 1992. She was at an office where they had their own technician in a laboratory, a dental laboratory, as part of the office. And the two of them put this together. She'd have pink here, and she would still have the same spaces she had before she had this. The only difference you're going to see between 1992 and 2013 is 21 years later. The difference you're going to see is in 1992, we used film for photographs. Today, like you, we all use digital cameras. The colors of we're seeing the same thing here and here and here in 3 different colors. But in 1992, she didn't smile she smiled much better here when she got this. 21 years later, she smiled a little bit later. But the question you should be asking is, after you've done all this, have you really protected the bone? Have you avoided peri-implantitis? So we're interested in the implants where the holes are. And we can see here with a micro gap of 1992, you can see that we have about 1 millimeter of where we would get that that would be the micro gap. That was 92. So what does it look like in 2016? And again, we're not looking for the old implants in the back. We're looking for the implants with the holes. And what we can see is the bone is exactly in the same place. We've lost nothing. We've had no surgery we've had to do. We've had no, these are tough cases. There are people that lost a lot of bone. who we can control because we are so dominating about making sure that they get to the office every 3 months. Every patient in our office has 1 hour for their cleaning. And even if they have 4 teeth, they have an hour. And what we're seeing is there's a way to do this. Now it was 24 years. So then on another visit, I said, whenever I show your pictures, people ask how you keep your mouth clean. So I want to take some pictures, and will you show? We're going to use this to teach other people how to take. So she has to get through. No. Yeah. She has to get through, you can see it right here. She has it on a little plastic needle and she goes in and out through there. She does this at least twice every day. And the pink ceramics is doing fine. Again, the color has changed with different cameras. And it's 21 years. Then the dentist, the prosthodontist who did this case was out of town, and now his son is a prosthodontist. And at the end of 2019, in December, I got an email from the son, and here is 2019. He met the patient for the first time, and he took a picture with his camera, which I think is a better picture than my camera. And you can see the pink ceramics. So we have solved the anterior problem. It would have been very easy to fill in these spaces with ceramics, but the whole idea in her mind was that people would never know she had all this work. It's a shame. It would be good for us to have a patient like that. I'm putting this patient here. This is a very important, wealthy person. And the person I went into practice with, Jerry Kramer, when I finished my residency, and I spent endless time with the patients with these. And with this individual who, again, this is a true captain of industry, we taught him how to take care of his mouth. What you're looking at is he has arrived now for his 3-month visit to have his teeth cleaned. You can see that there's some stain here or here, or a little bit here. This is how he came to the office 3 months later after having his teeth cleaned. That's how good a job a busy male patient can do if they understand they're going to lose their teeth if they don't do it. Because look at all these teeth that he lost all those years ago. I mean, all the bone that he lost. But it's possible to control patients. Then there's some other things that we do. This is a woman from the Western ski area whose husband is a ski teacher, and they were skiing together, and she took a fall and she broke out the 2 missing teeth, and she's had a couple of bone grafts and they haven't worked, and she came to see what could be done. What you're seeing is distraction osteogenesis. We have put the appliance on here, and we've separated this, and we have an apparatus in here where she turns 1 turn every day, and then every week sends one picture as to what's happened here. And she doesn't want to wear, she's wearing a partial denture here, and she doesn't want to continue wearing it. So here's the setup. You can see now the two pieces of metal are just about touching, and they're going to separate. And they're going to separate to that distance of the red line. And one day when I got this photograph from her, I called and asked if she still had the screwdriver to turn, and she said, of course. And I told her that, I hate to tell you this, but I need to have it for another patient. So you have to send it to me today, Federal Express. And she said, come on, are you kidding? And I said, no, I must have it immediately. What I was afraid of was if she kept turning it, the bone would come to touch the mandibular teeth. We were getting very close. This is how she was with her provisional bridge. That's how she was with her terrible partial denture. So there are ways to solve people's problems. In 1988, I placed these 4 implants. I'm showing you the picture because on this day, the patient was going to have 2 more implants because she was mugged in, she was in Europe, and she was in a city, and somebody hit her and she fell down to steal her pocketbook, and both central incisors roots were fractured. So I want you to see how clean this patient can keep her mouth. Look at the quality of these tissues. Oh my God. Excuse me 1 second. Hi, I'm in the middle of giving a lecture. I'll call you back as soon as I finish. Excuse me. I want to show you with platform switching how it's possible to see if it works. I wanted to save this bone because it's right between the 2 teeth. And that's, it's easy to camouflage back here, but this is what you see when you look at somebody. And I wanted to preserve this. So we did this with platform switching. There's the bone. That was 2005, 2008, 2009, 2010, 2016. It's still there. And you can see that the bone is, everything is preserved with the platform switching. Nothing you ever do will work all the time. This was an old implant. It was there before. This is one of the first implants. But there's an old saying that you have to have an open mind. If you don't have an open mind, you're probably going to have an empty head. You have to allow yourself that there are new things happening that can work, but nothing works 100% of the time. But you look at the bone level around these 2 implants, it's fantastic. And then I had a possibility to have a human histology of a platform switch. This implant, I was on a little angle on, and the dentist refused to do this unless I took this out and put a new one in. So I told the patient, if you let me take out this implant, I will graft it and you won't miss it. And the bridge will be from here to here, and I will pay the dentist for your bridge. And this is why our research company doesn't make very much money. But she agreed, and here it is after 6 months. Here it is. Oh, we are getting pretty close, but let's try this. This is this man. They had the red tooth. He needs to have surgery here, not only to eliminate his pockets, but to find a sound tooth structure for the future. He claims that he never had here. He's 62 years old, and he would swear on a Bible that he never had teeth here. What can you do? Each one of these places needs to have some more tooth structure in order to place a new margin. So here's the surgery with a provisional. And here's the surgery afterwards. And if you look at the lateral incisor, you get an idea. When this dentist is going to prepare this tooth, he's going to have a good opportunity to. And here where this old filling is right here at the papilla. This is up here because it was pocketed. So I'm eliminating the probing depth. Same thing here, or you can see it here or here. So I'm giving, this is the provisional bridge is back in there. And this is going to provide this tooth structure for the future. That's healed. This is one of the most difficult prosthetics things that I've ever tried to do. Just for fun in the past, when I was much younger, I did. We have here a situation where we want to have the acrylic brought back to 1 millimeter underneath the gingiva. You can see that the gingiva is under complete control. This is what it looks like after it was relined. You can remember on this lateral incisor, there was almost no tooth. There was almost no tooth here, or here, or here. And we're ready to put the dentist is ready to put the bridge in. But this is what we expect of ourselves from a surgical point of view, that we're giving the dentist. The next picture is a different dentist, a new dentist. And he was afraid to extract teeth, so he was making the provisional bridge, and he made the patient come back to our office to have this tooth extracted. That's this incisor. It should never look like this. Your tooth preparation should never look like this with this bleeding. It's horrible. The epithelium will grow down, and in the end, we'll never have the same thing until we have the difference here to do anything, and the difference here to do anything from a health point of view is unbelievable. Here's the final case in the mouth. You can see this is on the model, and these are 1 millimeter metal that will go into the sulcus. And you can almost see some of the 1 millimeter. That was 1970. That's 1980. And 1990. There's no recession from anything. There's been no inflammation. This is somebody that with a red tooth and had no idea what was happening. And the radiographs stayed the same. Since I only have 4 minutes left, I'm going to skip over some of this. The man is a world expert in making different things out of clay. And he sits at his lathe every day and he grinds and the dust gets in his teeth and he keeps playing with his teeth. And he's now never been married. He's almost 50 years old. And he met a woman and they just came together perfectly. And she told him that I will marry you, but I'm not going to marry you in the church with teeth like this. You've got to do something about your teeth. Now you're seeing how much the patient could grind down, and I mean how he could grind down. But notice there's no loss of bone. People keep talking about you lose bone from occlusion, and when I was young, I was taught that too. But if you look at people that have ground their teeth to this thing, this is like a occlusal athlete, and tissue is without inflammation, and there's no loss of bone. The only thing is that the first thing you have to do is the crown lengthening before you can make the bridge. And this is a happy story because they got married. I think I've used up my 2 minutes. I'm sorry I didn't get to totally finish, but I think we had a pretty good idea of aesthetics. Maybe give me 1 more second and I'll show you. We have a collapsed pseudo class 3. We have a vertical dimension problem. We can work with the right side, left side. We don't have teeth. Provisional. And we have a subperiosteal implant. That's how far back. This is 1969. He started here and he finished here. So I think I hope I've passed on some valuable information or thought process for you. I again say that the key to success with these cases is treatment planning. You've got to know which direction to go in. And everybody can learn this. Every 3 years in Boston, we have a meeting with 85 speakers from all over the world, bringing to the account to the symposium the latest things that they have found to make work more predictable and easier to perform. But I am now finished with the lecture, and if I can, I'm going to make this, see if I can get this to where you can ask me questions. That's right. Okay. Anybody have a question? I'm going to, the question is, what will happen to the superior alveolar nerve during implant procedure? I have never had a problem with that, so I can't tell anybody how to handle it. Another question by Thomas Roderick is, when did the periosteal implant get replaced? It stayed with him until he died. It was put in 1968 or 9. and he died in 1994. How did you gain flap elasticity since your incisions are site specific? From almost all of my flaps are partial thickness, and this enables me to get release and bring me flaps together. It says reload this page for more questions. What do I do to reload? Well, I thank all of you for helping make this happen, and I hope that I've been able to give you some new ideas to think about. I thank all of you for helping make this happen, and I hope that I